Hello, and welcome to another episode of the Oncology Brothers podcast. I'm Rahul Gosain, and with me, as always, is my co-host and brother, Rohit Gosain. Today, we're excited to dive into some key breast cancer studies from the San Antonio Breast Cancer Symposium 2024. To walk us through this, we're thrilled to have Dr. Sara Tolaney from Dana-Farber Cancer Institute join us. Sara, thank you so much for joining us.
Oh, thank you very much for having me today.
Sarah, welcome. Sarah, over the next 15 to 20 minutes, we are hoping to cover 3 studies to conclude our series on San Antonio Breast Cancer Symposium 2024 highlights, starting off with DESTINY-Breast06, and then switching gears to DESTINY-Breast12, and then closing off with a practice-changing, late-breaking abstract PATINA study. Okay, let's dive into DESTINY-Breast06, which was first presented at ASCO 2024. Here we have an update from there. Sara, could you please walk us through the study design and its key findings?
Yeah, so this data, when it came out at ASCO, was definitely very exciting and I think practice changing. So this trial was taking patients who had progressed through endocrine therapy and then were getting randomized as their first chemo agent to get T-DXd or to get treatment of physician's choice chemotherapy, that being taxane or capecitabine. The trial was a little unique, though, because it not just included HER2 low patients, but it also included what we call HER2 ultra low patients, meaning patients who have up to 10% faint staining. So what within the category of HER2 IHC 0, about 2/3 of IHC 0 patients will have a little bit of HER2 staining, and so it's that group of patients. So the study was designed to assess the benefits within the HER2 low population as a primary endpoint, but did include 150 ultra low patients that were included in the overall analysis. And what we saw in this trial was that T-DXd did do much better than standard chemotherapy, both in the overall population as well as in the HER2 low population. And when we look specifically at the ultra low patients, the benefits looked pretty much almost identical to what we saw in the low population. So it did suggest that T-DXd, in essence, does better than chemo with a 5-month delta favoring T-DXd in terms of progression-free survival. But what we saw at San Antonio were the subgroup analyses. And I think this was important because we were trying to understand what are the benefits of T-DXd in patients based on other characteristics. So, for example, in this trial, you were eligible to go on if you had progressed quickly through a CDK4/6 inhibitor. So if you progressed, for example, within 6 months of your first-line treatment with an endocrine agent and a CDK4/6 inhibitor, you could go directly onto this trial. You didn't then need to get 2 lines of endocrine therapy before you went on. And so we were curious to know, how did T-DXd do compared to chemo in those patients who are really endocrine refractory and just blow through their endocrine therapy and CDK4/6 inhibitor? And how does that compare to someone who maybe had longer duration benefit on that upfront therapy? And what you saw was that, in fact, T-DXd has profound benefits in those patients who really are very endocrine refractory, because you look at those people who got less than 6 months on their first line endocrine CDK4/6 inhibitor, and you see, in fact, that the hazard ratio is in essence 0.4. So you're seeing a very large delta, over 7 months between the two arms. So even more than we saw in the ITT population. Whereas when you go to the other extreme and you look at the people who are on their upfront therapy for a long time, so more than 12 months, now you see that, still T-DXd is much better than chemo. The hazard ratio is 0.67, but the delta again is a little bit less than we saw in those patients who really rapidly blew through it. So I guess in my mind, I took this away to say, if someone has highly endocrine refractory disease, we should probably move them on to an antibody drug conjugate, and they probably should get T-DXd if they're HER2 low or ultra low. So I think this was helpful to see that this is probably someone you don't want to give another line of endocrine therapy to and move on to maybe capecitabine. I'd rather move that patient on to T-DXd.
Absolutely. This is exciting because we're talking about majority of hormone receptor positive patients fall in this category of ultra low or low classification. And as you've pointed out, the benefit was seen in all cohorts, be it based on tumor burden or their time on CDK4/6 inhibitors. And Sarah, you touched on this. This study is in first line after exposure to endocrine therapy. So a lot of us will be leaning on this once the disease is endocrine resistant. With that said, out in the community, how important is it going to be for us to make sure that the tumor is indeed ultra low HER2 or have no HER2 expression at all? Can we use this in all comers? And like 85% of the patients fell in this ultra low category.
Yeah, this is a tough question because right now I will say that first we're waiting on the FDA approval for use of T-DXd in this first line chemo setting, if you will, and how they will make the indication be for low and ultra low. But you're right, this is a tough one because most pathologists are not reading ultra low. Usually we follow ASCO CAP guidance, and so they report it as either IHC 0, 1+, 2+, 3+, and then they test FISH if you're equivocal. So our reports generally haven't said if you're IHC 0 within the zeros, do you have some level of HER2 expression? And so unless that changes, it's going to be difficult to actually use this in the community in the ultra low patients. I will say we did have conversations with our pathologists at our institution, and they have changed their reports. And now, at least at our institution, are reporting if they write IHC 0, they'll then write ultra low. So they'll tell you if it's null, ultra low, 1+, or 2+. And so we now know if they're candidates. So I think that's going to have to change to really be able to use this. But you bring up a really good question as well. Would it work in everyone? Would it work in a null patient who has absolutely no expression? And we don't really know the answer to this question. We had a little suggestion in the DAISY trial where they enrolled zeros, and we saw about a 30% response rate, but it wasn't differentiated based on null or ultra low. They did actually show this in their Nature Medicine paper that there were some cases of null patients where they didn't see ADC uptake, but they were seeing activity. And to me, it makes me think that there is a little bit of free payload that's probably resulting in activity. And so I think we need more data. And there is a trial that actually is now ongoing, DESTINY-Breast15, which is enrolling patients who have IHC 0 expression, and will tease out that null versus ultra low and help us better understand efficacy. But for now, I would say we don't have sufficient data to routinely use it in a true null patient.
And this is paradigm shifting because historically HER2 was positive or negative. Then we started pushing our pathologists saying, can you say 1+ or 2+ because of the activity with T-DXd here? And now the request is, let's talk about ultra low. So keeping our pathology colleagues up to date on this is also equally important. Okay, now moving on to another aspect of trastuzumab deruxtecan, its ability to have activity in intracranial disease. HER2 positive disease has the highest incidence when it comes to intracranial disease. With that in mind, Sarah, can you touch on DESTINY-Breast12 and its recent updates?
Yeah, so I think this was a really important study. This was actually presented by one of my colleagues, Nancy Lin, at ESMO originally. And this trial specifically had two cohorts of patients. One was a cohort of metastatic HER2 positive breast cancer patients that had brain metastases. And the other cohort was metastatic HER2 positive breast cancer without brain metastases. And these were patients who had received up to 2 lines of systemic therapy in the metastatic setting. And so it was really trying to give us a larger number of patients who had brain mets, and we're trying to understand efficacy of T-DXd in this setting. Prior to this trial, we had seen a few small studies that had reported, studies like Tuxedo and Deborah, where we were seeing very robust intracranial objective response rates with T-DXd in patients with active brain mets, but the numbers were very small. Most trials were under 50 patients, and so we didn't have large numbers of patients to truly understand what the benefits were. And in this trial, there were about 250 patients on each arm. So this is the largest data set that we have for patients with brain metastases, with that second arm really just being a sort of simultaneously enrolling control to kind of see how efficacy compared to patients who did not have brain metastases. And what we saw was that, in fact, T-DXd does have robust efficacy in the brain. We saw that there was about a 70% intracranial objective response rate, that there was about a 17-month progression-free survival. So again, very robust activity. One cannot cross-trial compare the study, though, to, I think everyone in their heads is thinking, well, how does that compare to HER2 for example, where we know that capecitabine, tucatinib, trastuzumab has robust efficacy in the CNS, but they're very different patient populations. HER2 was more pretreated, so hard to sort of put simultaneously side by side, but nonetheless, you're seeing very prolonged PFS, more than what we've ever seen in a patient population with brain mets before, and very high intracranial objective response rate. And then at San Antonio, we saw these data with regards to the PROs and the health-related quality of life, really trying to understand what the impact is of T-DXd in someone with brain mets. And then they also looked at it in the cohort without brain mets. And in fact, what they saw was actually similar results in both cohorts, so that if you looked at deterioration-free rates at 12 months, they were over 50% for cognitive, emotional, physical, social functioning, and global health-related quality of life. So really suggesting that, we are not having significant deterioration in QOL in either arm. So I think very important data. Not only is it efficacious, but generally not having a significant impact on quality of life either.
Thanks for covering that, Sarah. Especially these trials, HER2 along with T-DXd, these are commendable to include brain metastatic patients because these are poor prognostic markers and they are usually not included. So having that evidence of intracranial activity and enrolling these patients in clinical trial is vital. And also to see that quality of life is not being compromised is important as well, though we have been able to extend the survival, but important is the quality of life data. Now, with the intracranial disease, as you mentioned, that we have two viable options, that is T-DXd or tucatinib-based regimen. Sarah, how are you maneuvering through in terms of sequencing? Are you relying on T-DXd? Though, again, I don't want to harp on the cross-trial comparison here, but what is your sequencing here?
Yeah, no, it's a really good question. So I'll say currently we are using THP in the first line setting, and we'll, I know, talk a little bit more about that first line setting based on some data that came out at San Antonio. And then after progression, we'll usually use T-DXd based on DESTINY-Breast03, which in fact showed us that you get about a 28-month progression-free survival with T-DXd in that second line population. So the question then comes up, well, what if you have someone who has brain metastases after THP? Are you going to choose HER2 or are you going to choose T-DXd? And, I don't want to say there's a wrong or a right answer, but I will say generally my preference is T-DXd, even for the brain met patients, because the PFS that we're seeing is really unprecedented. Again, we've never seen 17-month PFS in a brain met population. We've never seen 28-month PFS in the metastatic HER2 positive setting in a pretreated population. So, I think it's hard to beat. Right. And so I think I just feel comfortable using it in that setting. So I make a decision about whether or not I want to give local therapy first. If someone has one or two lesions that are easily radiated with SRS, I'll do that. And then if they've had systemic progression, then usually move them on to T-DXd. But you can also think about treating patients without doing local therapy with T-DXd, since it does have robust activity, and carefully following both systemically and the CNS.
Indeed.
Rohit, often our patients are asking, am I living longer and am I going to live better? Most of the drugs offer one or the other. Here with T-DXd, health quality outcomes, and the PFS, we're seeing both. That, at least in my practice, Sarah, that has been my sequence, exposing them to T-DXd and then relying on tucatinib, capecitabine combinations.
Right, I'd say, Rahul,
a good point about the quality of life issue too, because there are side effects of T-DXd. I don't want to downplay that, but at the same time, it has such impact with efficacy that I think patients' symptoms actually get so much better because they have less tumor burden, and they're feeling better, which is important.
Right. At the end of the day, we cannot forgo the ILD that comes along with it, alopecia, GI side effects. So again, putting all quality of life and survival data in pack together. Now, moving along into our last study, which is in fact practice changing, PATINA Trial, which is for triple positive metastatic disease. Sarah, could you please go over the study design and findings here?
Yeah, this was a surprise presentation at San Antonio, where the study team just got these data a week before they presented it. So very impressive. Yet again, San Antonio pulled off a very late breaker into the program, but exciting. So this study took patients who have ER-positive, HER2-positive breast cancer, and they had undergone induction chemo with dual HER2-directed therapy, in essence. So, for example, the way we give induction THP, a la Cleopatra, we usually give 6 to 8 cycles. For those patients who respond to therapy or have stable disease, we often will stop the chemo and put them on their HP maintenance. For those patients who have ER-positive disease, we usually add endocrine therapy to that backbone. So this study is saying for those patients that would normally go on to get HP endocrine therapy, we're going to randomize them to get that with or without palbociclib, with the idea being that we had known that CDK4/6 inhibition has activity not just in ER-positive, HER2-negative disease, but we had seen now several studies that have shown activity in ER-positive, HER2-positive breast cancer. And so the thought was, could you use it as a maintenance strategy to really extend the time of disease control? And so this study was designed to look at progression-free survival, but important to note, they started their clock at the time of randomization. So it didn't start at the time of initiation of chemo. It was after the chemo induction that people were randomized, and then we're looking at progression-free survival from that point forward, so with the maintenance portion forward. And what we saw, I will say, really surprised me, because if you look at the control arm here, so again, people getting HP endocrine therapy, you're seeing a progression-free survival of 29 months. So remember, if you go back to Cleopatra and you look at people who got THP and then went on to HP maintenance, they did not get endocrine therapy in Cleopatra. So the ER-positive subgroup did not get endocrine treatment, and their progression-free survival overall was around 18 months. And I would also remember that in Cleopatra, only 10% of patients had seen prior trastuzumab in the early stage setting, where in this trial, 70% of patients had seen trastuzumab-based therapy in the early disease setting. So this is a different patient population, and we're seeing a very different control performance. But I would also caution that I think the reason we see the control do so well, and this was pointed out very nicely by Sarah Hurvitz in her discussion, was that they kind of passed a test, right? They had to get through 6 to 8 cycles of chemo and not progress. Right. And so we took the good actors, the people who are very HER2 sensitive and would do well, and then we randomized them. So again, we selected out those patients. Right. And again, I think that's why we see the control do so well. But then you're seeing a 15-month delta in terms of improvement. So the PFS in the intervention arm was 44 months. Again, really blew it out of the waters. I will say this is something I've not seen before in a first-line population. So I think definitely practice changing, and would suggest that if you had an ER-positive, HER2-positive patient who gets through induction chemo with HP and does well, then you should shift them on to HP maintenance with endocrine therapy and CDK4/6 inhibition, and really should become a new standard of care option.
Can we take a minute to appreciate how impressive it is that on metastatic disease, first line, patients are living close to 4 years. This is very impressive. Sara, we've been talking about trastuzumab deruxtecan in previous 2 studies, and we see that this continues to move earlier and earlier. You're leading this effort on DESTINY-Breast09. Now with data of PATINA in hand, if both were to become available, what will be your treatment algorithm in this triple-positive disease look like?
Now that is a good question. So I think we're anticipating we could see data from DESTINY-Breast09 next year. That study had looked at T-DXd with or without pertuzumab and compared it to THP. But I think, as you're alluding to, in that trial, there was no maintenance strategy. They just gave T-DXd until time of progression. So you could imagine, let's say the PFS ends up being in the 30-ish month range, 33, 36, whatever months, if we want to guess. That means that people are on T-DXd for, 3 years potentially, right, until they progress. And so, the question I think now is going to be, if that study is positive and shows a very robust PFS, could we then think about moving to an induction maintenance strategy where maybe you give T-DXd up front, maybe the same 6 to 8 cycles, and then you move on to HP maintenance, endocrine therapy in the ER-positive patients, for example, with the CDK. So there is a study that's actually ongoing called the DEMETHER trial, where they are giving upfront 6 cycles of T-DXd, and then they're following that with HP maintenance, just as a single arm study. So it's, a small phase 2 experience, but that will at least give us some initial data for that type of a strategy. So I think we'll need to do more work here to move towards that kind of a strategy. But I think that's what we'd all love to see, is, potentially induction T-DXd followed by maintenance would really be nice.
And Sara, just before we wrap up, last question. This study was with palbociclib. Would you lean towards abema or ribociclib in this particular patient population? We also saw a retrospective study where all 3 CDK4/6 inhibitors had very similar outcomes in real world. So if you are going to lean into CDK4/6 inhibitor in this particular patient population, is palbociclib the right agent, or abema or ribo?
Yeah, no, good question. We in the ER-positive, HER2-negative disease, this keeps getting discussed, right? Because as you pointed out at San Antonio this year, there was some really nice real-world data showing OS was actually very similar across all 3 agents. I think here, though, the question's a little different because we are combining with trastuzumab and pertuzumab. And so I think you bring up a good point, which is actually you should not use abemaciclib in this setting, because we actually had done a phase 1 trial looking at combining abema with HP, and we did actually see quite a bit of GI toxicity, as you could imagine, given that both pertuzumab and abema do cause diarrhea. So I would say I would stick with the palbociclib, given that that's what was studied here. There is safety data, however, and actually a very nice study done with ribociclib in this setting. So, if someone had an issue with palbo and you needed to switch them to ribo for some reason, I think it would be okay because there's safety. But certainly, I think the choice here is palbo. We have a phase 3 trial showing efficacy, and we have very robust safety data.
Thanks for covering that, Sara. PATINA is indeed practice-changing, given such a dramatic PFS improvement, but we'll eagerly await T-DXd data in frontline settings. Though, as you pointed out, Sara, that this data is with palbo, there are some safety concerns with abema, and again, not well established with ribo. So for now, continue to utilize this with palbociclib. Sara, thank you so much for taking the time to go over these important practice-changing abstracts from San Antonio Breast Cancer Symposium 2024 with us. For our listeners, let us go over a quick recap. Rahul, we've now wrapped up our series for San Antonio Breast Cancer Symposium 2024 highlights.
Yeah, over the 3 episodes, Rohit, we've covered 10 studies from SABCS 2024. Today, with Dr. Sara Tolaney from Dana-Farber Cancer Institute, our focus was on DESTINY-Breast06, DESTINY-Breast12, and PATINA Trial. There is a lot to unpack here. Rohit, what are you going to put into practice based on what you've heard today?
Indeed, T-DXd is clearly an active agent, including its ability to respond to intracranial disease, and then again, sequencing it with tucatinib thereon. Though we eagerly await for DESTINY-Breast09 for T-DXd in early line for hormone receptor positive and HER2 positive disease. But at least at this time, we have PATINA trial with THP followed by CDK4/6 inhibitors and endocrine therapy, which is palbociclib, which again appears very promising based on PFS data. Thanks for joining us. Make sure to check out our other conference highlights, treatment algorithms, and recent FDA approval discussions. We are the Oncology Brothers.